Good afternoon, everyone. I'm going to talk about a slightly different aspect of the cataract surgery. I'm going to talk about the uveitic patients as a specialized group of patients and what sort of lens implant can be implanted in them. I'm going to share my experience regarding the capsular and uveal biocompatibility at 3 years following hydrophilic lens implantation in the eyes with a history of uveitis. The purpose of the study is to find out the uveal and capsular changes and the pattern of the lens epithelial cells migration at 3 years following the Rayner 570H hydrophilic lens implantation in eyes which had a history of breakdown of the blood aqueous barrier. We found 24 eyes with history of blood aqueous barrier breakdown and who also had the implantation of the Rayner hydrophilic lens in the bag. Now, 18 of these patients attended the follow-up at 3 years and had retroillumination, high-resolution digital photographs taken. And then each photo was examined for pigment deposits, implant precipitates, posterior synecdoche, LEC migration, anterocapsular phimosis, and posterior capsular opacification. If you look at the breakdown of these cases, 15 eyes had history of diabetes and history of uveitis, with diabetes being one of the predisposing factors. 4 eyes had pure past history of uveitis. 2 eyes had past history of trabeculectomy with posterior synecdoche. 1 eye had iridotomies with fixed pupil with single posterior synecdoche. 1 patient had a past retinal detachment surgery with post-surgical uveitis, and 1 eye had a traumatic uveitis. Let's look at the results. As regards pigment deposits, we did not find any visible pigments at 3 years in any of these eyes on these photographs, nor we did find any implant precipitates in any of these eyes. Also, there was no posterior synecdoche formation with the lens implant itself in any of the eyes. When we looked at the migration of the lens epithelial cells, we found that the optic edge of this lens implant provided an excellent barrier. There was no case of anterocapsular phimosis or no case requiring any YAG intervention to deal with this. There were 2 eyes with obvious posterior capsular opacification and 2 further eyes required YAG capsulotomy. Now let's look at some of the examples here. As you can see, at 3 years, this lens looks quite clear and there's a nice round rhexis. There is no phimosis, and you can see that the lens epithelial cells, they stop outside the square edge of the optic, and the posterior capsule has remained nice and clear. In this case, you can see a little bit of fibrosis there of the posterior capsule, but the lens epithelial cells did not migrate further. And you can see the lens is nice and clear, and there is no capsular phimosis. So another set of eyes, similar scenario, you got a very nice clean lens here, and here also nice clean lens with lens epithelial cells stopped outside of the optic edge. And again, there is no capsular phimosis. Another set of eyes with similar results you can see. And in this case, you can see some of the epithelial pearls breaking down from there and trying to come towards the center. But you can see that there is no obvious capsular phimosis or opacification of the anterior capsule. It remained very clear despite past history of blood aqueous area breakdown. This is 1 eye which showed some signs of PCO. The other eye looks clear. So in conclusion, I would like to say that we found excellent uveal as well as capsular biocompatibility with the hydrophilic Rayner centriflex lens. And the results of this specialized group of eyes with a history of uveitis as a risk factor are quite comparable to what one would find with the best cases results without any risk factor, particularly when we use a hydrophilic Rayner lens. Thank you very much.